This probably all started back in 2019 after I had my second child. I was just a typical mom experiencing some fatigue, some joint pains, intermittent fevers, a couple rashes here and there.
This is Jen Swisher. She's an emergency medicine PA in Southern California and a medical editor on our EM team here at Hippo.
I'd asked my primary care PA, who's amazing, for a referral to rheumatology. She ran some initial tests, and I did come back borderline for ANA as well as my rheumatoid factor. So I saw the rheumatologist. They had gone through the workup for lupus and RA and a few other things. The reflex confirmatory tests came back negative, and at that time, the rheumatologist had said, "You're just a mom and you're tired." And so I had accepted that and moved on with life. I'm an ER PA, working the night shift, and I just chalked it up to being tired and being a mom.
In this conversation, we'll talk about her personal and professional journey with dermatomyositis. She has become an expert in the subject from her own experiences as a patient and also her extensive research and advocacy as a healthcare professional. We'll hear more right now about how she reached her own diagnosis before we'll get into the presentation, workup, treatment, prognosis, and so much more.
And it wasn't until after I had my third child in June of 2022, I started experiencing some right hip clicking. I had a labral tear in my right hip from before it was small. So I'd asked my orthopedist to order an MRI for a follow-up because I had just given birth and thought, maybe the labral tear was worse. I don't know, being deconditioned. And that came back showing diffuse muscle inflammation on the MRI. At the same time, I was having rashes and seeing a dermatologist, and it wasn't responding to anything, so they actually took a biopsy. The biopsy came back showing that perivascular infiltration that you see with autoimmune conditions. And I put two and two together that there was an autoimmune condition occurring. And I had already been seeing a concierge rheumatologist. The other rheumatologists around here have an 8-month waiting list. He was going down the lines of seronegative RA since my dad has rheumatoid arthritis. And it was after the biopsy had come back and the MRI results that I asked him to add a myositis panel on to the testing. And he said, "Sure, I'll humor you, Jen, but it's not dermatomyositis." And I said, "That's fine, just humor me." A week later, it came back showing positive TIF1 gamma autoantibody for dermatomyositis, and my entire journey began.
I am so glad that you advocated for yourself and, to have heard at different points along your journey, you're just a mom, whatever that means. You're just a mom, you're tired, I'll humor you. And look, you knew all along what was going on.
Yeah, it was my first introduction into the trendy term medical gaslighting, right? And just being told that you're just a mom or there's nothing wrong with you or it's anxiety or any number of things. I'm a high-functioning emergency medicine PA with 3 children. My husband's a firefighter. I didn't have time to be sick. And so my main goal was let's just figure this out and get over it.
So let's get into myositis and dermatomyositis. What is it?
Dermatomyositis is a part of the myositis family, which is an inflammatory condition typically included with a lot of the idiopathic inflammatory myopathies. Think polymyositis, dermatomyositis, juvenile myositis, sporadic inclusion body myositis. There's a ton of them, but it really is under the umbrella of neuromuscular disease in which the presenting symptoms are muscle weakness, and you can get other symptoms along with it, including rashes, calcinosis, lung complications, things to that nature.
How common is it?
Dermatomyositis is pretty rare. Happens in, less than 10 cases in a million. So 1 in a million if you think about it that way.
And you mentioned several different kinds of conditions that fall within that autoimmune myopathy or inflammatory myopathy umbrella. We're going to really focus today on classic dermatomyositis. Do we have a sense of what causes it?
So there are a lot of theories out there right now. Autoimmune, typically there's a preceding viral infection, trauma, specifically for dermatomyositis and the autoantibody I have, TIF1 gamma. They think there's also a cancer-associated paraneoplastic syndrome. Specifically with mine, it's photosensitive, so UV exposure. So those are a few of the things, but there's no one leading theory as to what causes it. You either have that switch for the autoimmune condition or not, and something inflammatory turns it on.
We know that it's rare. Do we know whom it affects more commonly?
Typically, it's adults 40 to 60 years old. So when my symptoms started just shortly after 35, I was considered quote unquote young for this. And just like every autoimmune condition out there, you see a predisposition for females. There's also juvenile dermatomyositis that you have to think of, which has that bimodal distribution between ages 5 and 15.
You shared some of the symptoms that you had been experiencing. What are the textbook symptoms of dermatomyositis that we should know about?
Proximal muscle weakness is the number one. Shoulder girdle, like your biceps, triceps, femur areas, quadriceps. And then the rashes are the other big things. Dermatomyositis is one of the most testable conditions for us in PA school, medical school, because there are a million pathognomonic rashes that go along with it. The Gottron's papules that you see over the knuckles, the extensor surfaces, the heliotrope with eyelid edema and erythema. There is a pseudomalar rash that people confuse with lupus, but it also includes the nasolabial folds, so that's what differentiates it. And there are several other signs. There's the shawl sign, holster sign, among a bunch of different other rashes you can get.
I want to drill down on a couple of those so that I'm really clearly picturing the right kind of skin manifestations. I always remember the heliotrope eruptions. They're more on kind of the eyelids. Is that correct?
That is correct, and they're typically bilateral. I will say my case was unique and didn't read the textbook, and it was unilateral and actually underneath my eye, and I had more of the eyelid swelling with just the rash affecting one eye on the underneath side. So it may not look the same. It also may not look the same in those with darker skin.
Okay, so that heliotrope eruption, we think of it as being bilateral upper eyelids, but it can be unilateral, it can be below. I'm glad you mentioned how it may appear differently on different skin tones. I usually think of it as being kind of a reddish purplish color, but it might look different depending on the patient in front of us. I always think of those Gottron's papules that you mentioned, which are on the extensor surfaces of the fingers and the finger joint specifically. I usually think of them as being sort of reddish purple too. Is that accurate based on at least what the textbooks tell us?
Correct.
You mentioned the shawl sign and the holster sign. Can you tell us what those are?
Those are an erythematous rash with the shawl. It looks like you're wearing a shawl. Thinking about dermatomyositis, the rashes are going to occur where the sun touches the most easily. So you've got your upper anterior chest, top of the shoulders, your nose because it's closest to the sun, the extensor surfaces like the top of your knees. The holster sign is interesting if you were holstering a gun. So just like right there on your lateral hip is where you get another erythematous rash.
Oh, that's so interesting. So there's a whole range of skin findings that, you're right, show up on boards questions all the time. How do these skin findings show up in relation to the proximal muscle weakness that you described?
So they can show up together or one can precede the other. So in my case, the muscle weakness started first and then the rashes kind of were intermittent but became more persistent as the muscle weakness progressed. I first noticed my muscle weakness as right hip clicking, and that was just because of the inflammation that was occurring in the muscles. As I looked back in hindsight, I was having difficulty standing up off the stool at work. I was having to fling myself kind of out of the chair. So when the neurologists were doing my tests and all of a sudden they asked me to stand from a chair, they asked me to cross my hands and stand from the chair because I was compensating and flinging or pushing off with an arm. So I think that's really important to isolate that to see if there's truly weakness, especially when it's in that mild spectrum.
When I think also of proximal weakness in the shoulder girdles, I often think of if someone raises their hands over their head for getting a glass from the pantry or styling their hair, that's where those kinds of anecdotes will come up about how they realize that their shoulders are weak.
The hair thing is exactly the first symptom I noticed. I was unable to sustain holding my hands above my head to do my hair for more than a few seconds at a time without having to take frequent breaks.
So if someone comes to us with symptoms of either proximal muscle weakness or these new rashes or both, is there anything else we need to really drill down on in terms of history or our physical exam?
There are a couple other physical characteristics that are important to notice. With dermatomyositis specifically, you can get periungual nail fold changes. They also get mechanics hands, which are some dry papules essentially on the fingers. Lung involvement for those that may be affected with interstitial lung disease, which commonly occurs with dermatomyositis as well.
So after we've done a more probing history and looked for those specific findings on our physical exam, really good skin exam, nail exam, like you mentioned, looking at all their joints, listening to their lungs really carefully, how do we actually make the diagnosis? Is there sort of a magic panel of tests that we should be sending off?
That's a really good question, and that would make this really simple, and it's not. However, there's always a good place to start, and that's going to be your general labs to include LFTs because you want to see if there's any transient elevation of your AST, ALT. CK is the thing that you get tested on all the time. However, not all cases of dermatomyositis show inflammation in terms of an increased CK level. My CK never rose, but it's always monitored. And we also order a amylase along with it and a aldolase. When you're initially doing the rheumatological workup, you're going to want the ANA, your lupus antibodies, and rheumatoid factor because a lot of the symptoms cross over with RA. But if you're really thinking dermatomyositis, polymyositis, I would get a myositis-specific autoantibody test. You can initially get that through any of your typical labs. However, they are notoriously inaccurate, and most myositis experts recommend getting your specific autoantibody testing through the Oklahoma Medical Research Foundation, which can actually take a couple months to result, but is most accurate and will give you much more specific information about your autoantibodies for myositis. So typically people will start with a local lab and then do a confirmatory test with the Oklahoma testing.
Now, typically, will the labs that we work with then send the sample to the Oklahoma Medical Research Foundation, or do we as clinicians need to sort of look into that before we send our patient to the lab?
If you are an amazing clinician who wants to do all of their own lab testing and just likes having those connections, I would actually reach out and find out how to order your own testing. There is not any reflex testing through local labs. Usually it's just the myositis experts who have connections to the Oklahoma testing. Speaking of antibody testing, we are taught that anti-Jo is the most common autoantibody for dermatomyositis, when in fact, over half of cases are TIF1 gamma, which is the type of autoantibody I have and is the cancer-associated dermatomyositis. So that's just something to keep in mind.
Well, honestly, my reflex in my brain is to think of anti-Jo when I think of dermatomyositis because it's been drilled into my head since school. And I hadn't heard of TIF1 gamma until preparing for this conversation with you. So that is a really huge pearl in my mind.
Interestingly enough, each of the autoantibodies are associated with different clinical manifestations. So for TIF1 gamma, you're going to see skin manifestations and maybe some photosensitivity. And you have to really worry about those annual screening for occult malignancies for the first 5 years after diagnosis. Whereas if you're looking at NXP2, you may find more calcinosis associated with that. So each of them have their own specific clinical manifestations. So it is important to know the autoantibody and what you're looking for.
So now we've ordered whatever antibody panel tests we have available to us. We've ordered lab work. Is there ever any more advanced diagnostic testing that we might order?
Absolutely. Typically, you're going to want to get an MRI first to look for muscle inflammation, or an EMG to find the stereotypical findings you would see with muscle weakness in those proximal girdle region. Skin biopsies are typically done. However, they don't show very specific findings. Muscle biopsy is pretty invasive, and it's usually used last line. So in combination, you've got MRI, you've got EMG, you've got a skin biopsy, and you've got a muscle biopsy. Any combination of those with a typical rash and enzyme or autoantibody findings is going to lead you to your diagnosis.
And depending on our practice setting, we may be able to order some of those tests on our own, but we may also really be needing to rely on some specialist colleagues to help us with others.
Absolutely.
I imagine most people with dermatomyositis are going to be treated by rheumatologists, but I think it's really important for all frontline clinicians to know what are the pillars of treatment. Can you talk us through these?
The first line of treatment is going to be your glucocorticoid. So high-dose steroids is what's going to reverse that muscle weakness and give you the biggest bang for your buck.
Are there examples of the types of steroids we might prescribe and also what kind of dosing regimens?
Sure. So prednisone is going to be your go-to at 1 to 2 milligrams per kilogram per day. You're going to need to be on a high dose for a decent amount of time, essentially as long as it's going to take you to get into rheumatology, which may be anywhere from 6 to 12 months. So if you're in the outpatient setting, you're not going to even have to worry about starting to taper them because they should be able to get into rheumatology before a taper is needed. And like I said, we're talking high dose prednisone for at least 6 months.
Right, like a 70-kilogram person would be on, at minimum, 70 milligrams of prednisone a day.
Correct.
What about any off-label treatments that our rheumatology colleagues use for so many different kinds of diseases?
There are a lot of clinical trials going on. However, most regimens are going to be fairly similar to that of RA. So think IVIG, rituximab, methotrexate, depending on which myositis expert you see, and also which autoantibody you have.
What has your treatment regimen been like?
When I was first diagnosed, I was still breastfeeding, so that was a huge consideration. You can't take very many rheumatological treatments when you're breastfeeding. We started off on IVIG and high-dose prednisone, so that way I could continue breastfeeding. But then when I saw a myositis expert at UCLA a couple months later, she taught me that dermatomyositis needs to be hit hard and fast. And so that was the end of my breastfeeding journey. I was on a high dose of mycophenolate, IVIG, as well as high dose prednisone, and saw really good results at about 6 months. Unfortunately, we tapered my prednisone a little too quickly. I went back into a flare a few months later, and we had to up the mycophenolate to the maximum of 3 grams a day. I remained on IVIG and just recently started on rituximab.
We're going to talk more about your journey in its present day in just a moment. I imagine that lifestyle measures are a really important part of how we talk to our patients about this disease as well. What kinds of lifestyle measures should we be counseling them about?
Absolutely. And again, this is going to be autoantibody specific, right? So mine with the TIF1 gamma, I'm photosensitive. I have to avoid UV radiation like it's the plague. So that's a big one. The typical anti-inflammatory diet is the way to go. The other aspect is a good exercise regimen, starting low and slow. It actually is to the benefit to do a gentle strengthening regimen.
You mentioned anti-inflammatory diet. What does that entail?
If you ask most rheumatologists, they'll go with the Mediterranean diet, but essentially it's cutting the fat out and decreasing your alcohol intake. Another important point is that you want to increase your antioxidants, but you also want to be cautious about not taking those immune boosting agents that seem to be a good idea, like the things that you would find in a green drink, like spirulina and things to that nature.
What is a typical course for dermatomyositis, if such a thing even exists? Does this get cured? How do people do with it?
The hope is for remission. The goal, typically, if you speak to any myositis expert, is to have low disease activity. We know the 5-year survival rate is greater than 95%. And typically, a majority of patients will do well without functional disability. All in all, about 40% of patients will have a monophasic illness, which means that they'll do well, and they may end up in a remission. However, 20% of those patients will end up in a relapsing and remitting course. And then the other 40% that we're talking about will end up having a chronic progressive disease. The other thing that you have to keep in mind for TIF1 gamma specifically and any of the other cancer-associated myopathies is an occult malignancy. It's important to do surveillance annually for your typical malignancies for age-appropriate screening.
Well, you read my mind because literally, Jen, I was about to ask you about the increased risk of cancer with dermatomyositis and with that TIF1 gamma autoantibody variant that you have shared that you have with us. So what do we need to be thinking about in terms of more rigorous screening?
Specifically with TIF1 gamma, you're going to see the majority of cases is that first year. However, most experts state that the increased risk of malignancy occurs within the first 5 years of diagnosis. And there's not really any specific cancer. We do know that breast, ovarian, gastric, and lymphoma are the big guns with TIF1 gamma. And so you start with all of the typical baseline screening, mammograms, pap smear. I do a transvaginal ultrasound annually to look for ovarian cancer along with a CA-125. The other screening that we typically do are CT, chest, abdomen, and pelvis. Some people will include the neck with contrast to screen for occult malignancy as well.
That feels like a full-time job in and of itself, honestly. Just the screening tests, let alone all of your visits for treatment.
You couldn't have said that better. I joke that my part-time job is going to appointments and I've become a professional patient, and not to mention all of the little symptoms that come up. For example, I ended up with a swollen lymph node in my neck, and so primary care went ahead and ordered that thyroid ultrasound. So you just have to keep investigating things in order to just make sure that there's not something cropping up, especially in that first 1 to 2 years of diagnosis.
You said that so well. Like a person with dermatomyositis coming into me with a new symptom, with that person, I'm not going to be like, oh, we'll just keep an eye on it. Let me know if it doesn't get better on its own. I'm going to be investigating it like a hawk right away.
And I think that's the other thing is not only do you have all of these things associated with the disease itself, but you also have the complications and side effects of the medications and the regimens that they're on, right? So you think about high-dose prednisone, but IVIG, I think something that we're not taught is you have a much higher risk of clot. And so if somebody's coming in with shortness of breath, pleurisy, you're going to have to rule out that PE for them among a million other different things that are going to show up or crop up during this disease progression.
I imagine it's a little bit of a mixed bag to be an actively practicing clinician and also navigating this journey of being a patient with a very complex chronic illness. What has that been like?
So I think the one thing that a lot of people don't realize is the blessing and burden that comes with being both patient and provider. The burden is that it's hard to turn off your medical hat and you know too much. And so you can kind of get inside your head about some things. But there's also a lot of blessings that come along with that. You're an active member of that team and deciding what diagnostic tests or therapeutics are going to be had. And sometimes I blindly trust my team. For example, they suggested rituximab once I had this flare, and I just blindly trusted and didn't look into it and said yes and didn't look back. But when they wanted to do my annual screening this year for cancer, I had 3 imaging studies done in the last year, and I didn't want to add 2 more this year, including chest, abdomen, pelvis, and a breast MRI, because we don't know what the long-term effects are, gadolinium deposits in the brain and things like that. And I'm 38 years old. I have a lot more screening to go in this diagnosis and disease progression. And so I asked my team if I could opt for a PET scan. And while it may increase the radiation, I knew it would pick up an occult malignancy, but they're not typically approved for those who don't have active cancer. And so my team went through 2 peer-to-peers to get it approved. I was able to decrease my contrast load by 2 full imaging studies this year, which to me is a big deal. And so that is another huge blessing.
Can I ask, how are you doing now? That may feel like a loaded question, but how are you?
I think all things considered, I'm doing much better. I've become my own best advocate. We're all dealt cards in life, and we are not allowed to choose the deck in which we're given. I use this as a way to increase my empathy towards my patients and to increase awareness about this, because the thing with dermatomyositis is it can take years for patients to get diagnosed. Not everybody has the blessing to be a PA and have studied this and be able to put 2 and 2 together. I'm able to easily advocate for myself and ask for what I need and diagnose myself and get to the right people and right specialists.
I have learned so much from this conversation. I'm wondering what you think are the most important take-home points for all the clinicians listening to walk away with when it comes to dermatomyositis.
Let's just throw out dermatomyositis for a second. All you need to tell your patient is that you believe them. I think that's the first place to start, to say, I believe you when they come to you with symptoms. And then with dermatomyositis is you're looking for zebras and not horses, right? So if somebody's come to you with vague complaints that are not connecting the dots and things aren't necessarily looking textbook, think outside of the box and start asking more probing questions and just keep this in the back of your mind.
Well, Jen Swisher, I'm so glad that you are doing okay. I am so glad to know you, and I'm so grateful for your time in telling us your story and teaching us about this disease as both a clinician and a patient. Thank you.
Thank you so much for having me. And for anybody that needs more information, I can't encourage you enough to go to the Myositis Association. They have an entire physician guide on this, which can help direct both diagnosis, treatment, and referrals to tertiary care centers who are experts at this. Thanks again, Neda.